Hey everyone, and welcome to This Explainer. I'm your host, Harshal, and today we're diving deep into the high-stakes clinical reality and the super precise ICD-10 coding rules for traumatic fractures and acute kidney injury. We're literally bridging that critical gap between the frontline patient care going on in the ER and the accurate clinical documentation that has to follow. Let's get right into it.
So let's start with a pretty stark reminder right out of the gate. In acute care, an immediate risk of death or severe disability means that delay makes survival unlikely. Boom. That's the reality. It's a time-critical emergency setting, and honestly, that sets the absolute ultimate stakes for your clinical documentation. Because precision here, it's not just some administrative hoop to jump through, it's a direct reflection of intensive, literal life-saving care.
Here is our quick roadmap for today. We'll hit the acute emergency frontline, move into fractures and their clinical red flags, then cover coding fractures and sequencing. After that, we'll shift gears to AKI, the silent threat, how to code it, and finally, wrap up with our final coding takeaway.
Okay, part 1, the acute emergency frontline.
You know, when a patient first rolls into the ER, unstable vital signs are the absolute hallmark that critical systems are failing. We're talking massive red flags here, like a systolic BP tanking under 90, a heart rate skyrocketing over 150, or oxygen saturations dropping below 90%. Now, for coding, the principal diagnosis must be the main reason for admission, right? And acute conditions always take priority over chronic ones. But here is the absolute rule of strictness you have to live by. Your codes must be based on explicit physician documentation. Zero assumptions allowed. If the doc didn't write it, you absolutely cannot infer it just because you saw a low blood pressure reading in the chart.
Moving on to part 2, fractures and their clinical red flags.
It's honestly wild to see the mechanical variety of bone breaks you'll encounter in a patient's chart. They range from these simple, straightforward linear cracks to spiral fractures caused by intense twisting forces, all the way up to highly complex comminuted fractures where the bone literally shatters into multiple pieces. And guess what? Every single one of these variations completely changes the clinical approach and therefore the exact code you're going to select.
But we have to look way beyond just the break itself, right? As coders, you've got to watch like a hawk for limb-threatening complications. These are the details that totally spike the severity of your codes. You're looking for high infection risks, especially in open or compound fractures where the bone has actually breached the skin. Then there's compartment syndrome, which is this incredibly dangerous pressure buildup inside the muscle. And as the patient recovers, you have to watch for non-union, which is when the bone just flat out fails to heal, or malunion, where it heals in the wrong position, not to mention any nerve or vessel injuries along the way. Which brings us to part 3, coding fractures and sequencing.
So, when you're dealing with multiple fractures, you have to follow 2 very strict trauma sequencing rules. Number 1, code each fracture separately. No bundling allowed here. And number 2, always sequence the most severe fracture site first. So think about it. If a patient comes in with a totally shattered, comminuted open femur fracture and, say, a simple toe fracture, well, that femur fracture is driving the whole encounter, right? So it goes first in your sequence.
Now, your 7th character extensions basically act as a timeline for the patient's care. Think of it as a matrix. A indicates the initial encounter for active treatment, stuff like casting or surgery. D is for a subsequent encounter during routine healing. Then we've got S for sequela, which captures late effects like chronic pain. And remember those nasty complications we just talked about? You'll use specific characters like K for non-union and P for malunion during those subsequent encounters. All right, shifting gears to part 4, AKI, or acute kidney injury, which is truly the silent threat.
Unlike a bone breaking, which is pretty visibly obvious, an injured kidney is dangerously quiet. AKI is a sudden drastic decline in kidney function that happens over just hours or days, and it's triggered by systemic vectors. This could be anything from heart failure to low blood volume from shock or severe dehydration, sudden inflammation, or even the introduction of nephrotoxic drugs.
You can actually triage this silent threat into 3 precise diagnostic buckets based on the mechanism of the injury. First up is pre-renal, which is caused by decreased blood flow to the kidneys, often from dehydration or heart failure. Next is intrinsic, and this is direct tissue damage to the kidney itself, like acute tubular necrosis or damage from those nephrotoxic drugs we mentioned. And finally, post-renal, which is caused by a urinary tract obstruction. Think kidney stones or tumors blocking the flow.
To actually validate this diagnosis in your charts, you need to hunt for specific lab markers. You want to see blood tests showing elevated creatinine and elevated BUN. You might also spot urine tests noting abnormal electrolytes or proteinuria.
But crucially, you really want to look for explicit clinical criteria, like KDI geostaging notes from the physician, or imaging, like an ultrasound or CT scan that was used to detect those post-renal obstructions.
Part 5. Coding acute kidney injury.
Depending on the physician's exact documentation of that tissue damage, you are going to map the AKI to the N17 category. It is all about anatomical specificity right here. You have to carefully distinguish a code like N17.0, which is for acute tubular necrosis, that intrinsic damage, from something like N17.1 for acute cortical necrosis, or N17.2 for medullary necrosis. And look, if the chart is totally lacking this specific anatomical detail, well, you have to default to N17.9, which is acute kidney injury, unspecified.
Finally, Part 6. The final coding takeaway.
I really want to leave you guys with this one thought. How does a single missing seventh character, or an unverified lab value, alter your patient's entire clinical narrative? Honestly, it alters it completely. Missing an A for active treatment on a severe fracture, or failing to code the specific intrinsic cause of an AKI, it totally minimizes the intensive, life-saving care that actually happened in that room. Always remember that precision in the chart reflects the true reality of the trauma. Decode Healthcare with Harshal. I will catch you in the next explainer.